Welcome to this program, Myasthenia Gravis in the Complement System. I'm Professor James Howard, Chip Howard to many of you, Professor of Neurology, Medicine, and Allied Health at the University of North Carolina in Chapel Hill. These are my requisite disclosures. This educational program is funded through an unrestricted grant from UCB, in acknowledgement to CheckRare CE for their production. Let's begin. What is myasthenia gravis, or MG for short? It's an autoantibody-mediated B-cell disorder dependent upon T cells and complement. Characteristically, there's fluctuating weakness in a variety of muscle groups, typically the eyelid, the muscles of ocular motility, but may also include those of speech and swallow, as well as limbs. Ocular weakness is the most common presentation in generalized MG, with limb and bulbar function occurring in about 1/3 of patients as the presenting symptom as well. Its treatment is highly individualized and often includes off-label medications. Currently, there are 5 approved drugs by the US FDA. Eculizumab, the first in 2017, efgartigimod, ravulizumab, rozanolixizumab, and zilucoplan most recently. The symptoms and the diagnosis of myasthenia gravis can be varied and difficult to make. Characteristically, there's fatigable muscle weakness, exertional muscle weakness that is made worse by activity, improved with rest, only to recur with resumption of the activity. As such, individuals may develop variable double vision, droopy eyelids, intermittent slurring of speech, and intermittent weakness of their limbs. Hence, the long odyssey from symptom onset to diagnosis. The diagnostic strategy is first and foremost an exquisite neuromuscular clinical examination and history. This is supported by electrophysiology and serology. There are many protocols in terms of the algorithm which one uses to achieve that diagnosis. Often, if it's not severe, individuals have serology performed, looking for antibodies, particularly to the acetylcholine receptor, which we find in about 85% of patients. If it's more urgent, in addition to serology, electrodiagnostic testing is performed. Classically, repetitive nerve stimulation studies, and more recently, in very selected centers, single fiber EMG. In many institutions, these studies are performed simultaneously. With a confirmation of diagnosis, treatment is initiated. However, should serology be absent, then there are a couple of other antibodies that can be looked for. One is to muscle-specific kinase, MuSK, and the other is to LRP4. These occur in much less frequency, about 8% for MuSK and probably 1% or less for LRP4. Characteristically, if one can demonstrate a normal single fiber EMG in a clinically weak muscle, that is proof pudding, so to speak, that the weakness cannot be due to a disorder of neuromuscular transmission. Myasthenia gravis is associated with burdens. There is burden of disease and there's burden of treatment, and we'll speak about these as we go. When we talk about disease burden, talking about the impact on the psychosocial productive aspects of one's life. the Myasthenia Gravis Activities of Daily Living score, an MG-specific outcome measure that has been well validated, is shown here. And on the left, one sees that scores range from 0, normal, to fairly high in the 20s, which is abnormal. In more than 50% of individuals in this single data cut of a myasthenic registry demonstrated that the average score was 6.2. Highly significant disease impact on one's quality of life. To the right, we see an MG-specific quality of life index, and one sees that there are broad responses, and lower numbers reflect better quality of life. So despite the therapeutics that any of these individuals had received, substantial numbers of these individuals still have persistent impact on both their activities of daily living as well as their quality of life. This graph reflects where we've been and where we are recently going. Back in the early 1900s, there was a near 100% mortality with myasthenia gravis. This was primarily due to respiratory failure. The advent of antibiotics, the advent of assisted ventilation dramatically altered the slope and the course of myasthenia with improvement. Clearly, with antibiotics, there was more than a 50% reduction in mortality. And then over the last 50 years, we have seen this slope start to level out, become more asymptotic as we've added a variety of new therapeutics to our treatment toolbox. In the early 60s, in the early 70s, it was thought that myasthenia was an autoimmune disorder, and drugs like ACTH and corticosteroids were used with clear improvement in the patient outcome. With the recognition that there was indeed an antibody directed to the acetylcholine receptor, and this occurred in the mid to late 1970s, then there was a switch in our philosophy and to utilize things like azathioprine and cyclophosphamide and the cyclophilins, along with the advent and use of plasma exchange in the mid-1970s. And as you can see, over the course of time, we've added different immune suppressants, all non-specific in their mechanism, to aid us in the treatment of this disease. And it was not until 2017 when the first targeted therapy and first FDA-approved therapy for myasthenia gravis came about, and that was eculizumab, a monoclonal antibody directed to C5, complement protein 5, and the complement cascade. And subsequent to that, additional complement inhibitors and another class of drugs called neonatal Fc receptors were developed and are in clinical use at this time. Let's speak about the complement system. And if we go back to our medical school days, and much of it wasn't even known when I was in medical school in my training, it is one of the pathogenic mechanisms in AChR myasthenia gravis. There are three pathways that have entry into the complement cascade, if you will. One is the alternative pathway. The second is the lectin pathway. And the one we're most interested in is in the classical pathway, where antigen-antibody complexes initiate a complement response through the activation of C1. As the algorithm evolves, or the cascade evolves, evolves through C3, ultimately to C5, which is where our latest targets are. C5 is cleaved into C5a and C5b through the enzyme C5 convertase. C5b then combines with C6, C7, C8, multiple copies of C9 to form a ring-like structure that attaches to the surface of a membrane. It literally drills holes through the membrane, leaks its contents, leading to the destruction of that tissue. And this was initially recognized in paroxysmal nocturnal hemoglobinuria, atypical hemolytic uremic syndrome, and in myasthenia gravis was recognized in the mid-1970s by Andrew Engel at the Mayo Clinic. Antibodies to the acetylcholine receptor are of the subclasses, immunoglobulin subclasses of IgG1 and IgG3. And that becomes important because these two subclasses activate complement through C1QRS. And so the binding of antibody to the surface of the membrane of the acetylcholine receptor activates C1q and initiates the complement cascade. As I said, and as shown in this graph, the ultimate formation is the lytic structure, the membrane attack complex, now referred to the terminal complement complex, that drills holes and destroys the membrane tissue. However, there are other mechanisms involved in myasthenia gravis from a pathogenic perspective. Clearly, antibody binds to the target, not directly to the binding site in most instances, but to some other epitope on the membrane surface, sterically hindering the ability of neurotransmitter to get to the binding site on the receptor. And there are two binding sites per receptor complex, and both must be occupied by neurotransmitter for that ionic channel to open and allow flux of sodium to depolarize that membrane, leading to the activation of an action potential that is then propagated down the cell surface. In addition, binding of antibodies complex with each other, cross-link, if you will, and accelerate a normal turnover process of receptor protein. Receptors are internalized, degraded, and new receptors are popped to the surface every 7 to 10 days. That's muscle dependent, that's species dependent. And the presence of antibody accelerates that process. So in these first two mechanisms, the net result is a loss of available receptors for depolarization, a reduction in receptor density, if you will, which then leads to synaptic failure on the part of synaptic transmission. And then, as already mentioned, the third mechanism is the activation of complement and the subsequent destruction of the tissue. This slide here shows a little bit more close-up of what's occurring on. In the left-hand panel is a normal neuromuscular junction. One sees the classic post-junctional folds, and on the crest of these folds are where the receptors lie. The leg-like structures there drawn in black are the terminus of the nerve that releases acetylcholine. Then one sees to the right of that the activation of complement, destroying that end plate zone. And it's only in that left part that we're demonstrating this to you, which results in additional loss of synaptic transmission. More clearly shown here is what's going on. And on the left panel A, I'm showing you the location of acetylcholine receptors directly below the nerve terminal on the surface of these post-junctional folds. Binding of antibody in panel B inhibits the ability of transmitter to get to these receptors, as already mentioned, but more importantly, the activation of complement demonstrated by the large blue circles, which then results in this architectural destruction, if you will, by this membrane attack complex, terminal complement complex destruction of that post-junctional membrane. There has been data over the last 10 years that suggests there is weak correlations in serum complement levels and what's called the QMG, Quantified Myasthenia Gravis score. This is a manual muscle testing outcome measure that includes limb strength, eye movements, eyelid movements, speech, swallow, and respiratory function. And while the correlation is not phenomenal, there was a suggestion back then that there was indeed complement attack that was playing a role and related to the severity of myasthenia. More animal studies have been done than in humans, and our therapeutics have leapfrogged the basic science we need to fully understand what's going on at the neuromuscular junction in complement inhibition. But we have some good ideas. In the left panel, you see an experimental model of myasthenia gravis in which anti-complement protein 5 therapy was initiated. And the score range is worse is greater and is based on a clinical outcome measure. And we see that those individuals, the wild type, as seen here in the open bars, and those treated with complement inhibitors in the black bars, that there is clearly a better response in the clinical outcome over time when treated with complement inhibition. To the right, we're looking at immunocytochemistry on muscle in terms of experimental model, EAMG. In the top row, the wild type in the bottom row, and then EAMG treated with a different complement inhibitor, EV576. The first vertical column looking at Bunger toxin, BTX, which binds irreplaceably to the acetylcholine receptor. To the right of that in green is looking at complement protein C9, and then a merged photograph of the two. And one sees that Bunger toxin, which localizes receptors, merges with that of C9, essentially overlays the same territory, again supporting the presence of complement at the neuromuscular junction, playing its critical role. Other studies were done as well in experimental models with Van de Lennen back in the mid-70s, our laboratory as well, passive transfer models, demonstrating that complement was needed to induce the experimental model of myasthenia gravis. We talked about burdens of disease and its impact in terms of the quality of life and the activities of daily living. We clearly have increasing data on the impact on employment and muscle strength, etc. But there's also burden of treatment, and that's predominantly the adverse event profiles of the drugs we use and the logistics and how we can manage it. And at the top are those common therapies that we use. Cholinesterase inhibitors to the left, steroids, immune suppressant therapeutics, intravenous immunoglobulin plasma exchange, and rituximab. And one sees the list of side effects, potential side effects that can be encountered. And this is over short-term as well as long-term use. In addition, with some of these, there's an even more dangerous long-term use. For instance, with steroids, the potential to develop diabetes, osteoporosis, hypertension, to say nothing of weight gain. With many of our immune suppressants, there is malignancy risk. There's potential damage to the liver and to the kidney. And similarly with plasma exchange, we have a number of thromboses that have occurred with IVIG. We've had infection and sepsis with catheters used in therapeutic apheresis. And with rituximab, although exceedingly rare, progressive multifocal encephalopathy, PML, is of a concern. If one looks at registry studies, adverse event distaste represents about 45 or 40% of our patients. However, if one is on corticosteroids, that distaste goes up over 80%. While a very effective drug, it's a two-edged sword, and it's linked with all of these significant adverse events. Hence the need for new therapeutics. In addition, many of the immune suppressive drugs that we use, the cyclophilins, azathioprins, mycophenolates, cyclophosphamide, etc., have a very long latency from drug initiation to onset of effect, to say nothing of maximum effect. And in many instances, this is 4 to 6 months, and with some, it may be almost a year. Clearly, that's lost time for the patient. And again, a need for new therapeutics with restricted adverse event profiles and more rapid onsets of action. And you've seen this graph before, the history of treatment options, our mortality rates, and in this decade, patients should live a full life. Some literature would suggest 3% do not. It is my personal belief that if appropriately managed, individuals should not die from their myasthenia gravis. The two latest classes of therapeutics, complement inhibitors, as well as neonatal FC inhibitors, have rapid onset of effect within days to a few weeks, with maximum effect occurring within 3 to 4 months. Now, we have multiple ways to treat myasthenia, and this is a cartoon that demonstrates. Classically, cholinesterase inhibitors, a symptomatic therapy, has been used in myasthenia with a relative improvement in some, but not all, muscle groups. Interestingly, those individuals with MuSK myasthenia do not, or often do not, respond to cholinesterase inhibitors. We can also use corticosteroids. They target the immune system broadly. Same with most of our immune suppressive drugs. But it's with the complement inhibitors attacking the terminal complement pathway through complement protein 5 that much of our improvement of late has occurred. As we said previously, we have several FDA-approved treatments. In the neonatal FC receptor class, we have efgartigimod, which is used intravenously. We have efgartigimod in a subcutaneous formulation. This has been co-formulated with hyaluronidase because of the modest volume that's injected. We use the hyaluronidase to break down local collagen tissue and allow this volume to be absorbed very easily. This process has been used in oncology for more than a decade and very successfully. And more recently, we have rozanolixizumab, or ROSI for short, which is a subcutaneous infusion. These are either administered on 4-week schedules or 6-week schedules, and retreatment occurs when the patient has clinical deterioration or worsening. Complement inhibitors, initially eculizumab, a monoclonal antibody targeting C5, administered intravenously. Ravulizumab is actually eculizumab, but engineered genetically 4 amino acids to give it a longer half-life. So rather than every 2-week infusion, every 8-week infusion. And zilucoplan is very unique. It is a 15 amino acid macrocyclic peptide, but the targets of all of these drugs are the same, complement protein 5. Efgartigimod, the FC receptor, was approved in 2021, and it's approved for those who have generalized MG who are AChR positive. The initial trial was done in all individuals, and we saw very similar results whether one had antibody or not, but the approval process, because of the outcome measures, etc., for those who had AChR positive disease. The dosage is listed there, 10 milligrams per kilogram, weekly for 4 weeks, and then we base it on clinical evaluation. The subcutaneous form is similar. That dose is a bit different, and it's adjusted to have equal efficacy in the trial that we performed with it. And this subcutaneous injection over 30 to 90 seconds, and currently by a healthcare professional, though our hope is at some point it will be self-administered. Rosie was approved more recently in 2023, and its approval is for those who have generalized AChR positive or MuSK antibody positive disease. It's dosed based on body weight, and it's weekly for 6 weeks, and then again, subsequent infusions are based on clinical response. This requires an infusion pump to be administered. All of these drugs that we've just mentioned do not have any black box warnings. Let's turn to complement inhibitors. And the first was eculizumab in 2017, and again to treat AChR positive generalized myasthenia gravis. The FDA approval was for any individual with AChR positive disease. It's been used because of health ministry and payers restrictions to those who have failed other forms of therapy. It's dosed with a starting dose for the first 4 weeks and then followed by a maintenance dose, which is slightly more on an every 2-week basis. The infusion is short, about 30 to 40 minutes. It does have a black box warning because complement inhibitors increase the risk of encapsulated bacterial infection, predominantly Neisseria meningitidis, and in rare instances, Neisseria gonorrhea, and then streptococcal pneumonia and H. flu, the latter two in children for those who are quite infirmed. This was the REGAIN study that was performed. This was the phase 3, and one sees the protocol where screening occurred. Standard of care was administered and not changed during the course of the study, and one had to be vaccinated against meningococcus to gain entry into the trial. And we'll come back and talk about the role of vaccination towards the end. 1-to-1 placebo, blinded for 26 weeks, and then those who completed that trial were allowed to roll over into an open label extension trial. And one looks at the right to the drug and placebo drug arms. They were very well matched in terms of age, in terms of gender, like all myasthenia trials, predominantly Caucasian, with very few other races, although here, because we had Japanese centers, there were Asians here, 16 of them. And disease duration was long, nearly 10 years in both arms of the study. These are the results of the eculizumab trial. I want you to look at 2 portions. The first is on the left. One sees a vertical bar that splits the screen, so to speak. That first portion is the blinded phase of the trial. Red is placebo, blue is active drug. I'll call your attention to the fact that all MG trials have a significant placebo response. That can be as high as 60% in some trials, on average between 35 and 40%. But also one sees in the drug-treated arm of the study a very rapid and robust response occurring within the first week and seemingly stabilized around week 4 to 12 and then carried through to the end of the 26-week period. At the 26-week period where patients rolled over into the open label extension, at which time the placebo arm receives active drug, there in red, one sees a virtually identical curve to the original start of the study. And that placebo arm now, without a placebo response, because it's already built in, if you will, a rapid, robust response that then parallels the drug arm all the way out to 130 weeks, which was the termination for this data acquisition. On the top, we're looking at the Myasthenia Gravis Activities of Daily Living score, which was the primary endpoint. The MG-ADL is mandated by the US FDA as the primary outcome measure in all phase 3 MG trials. And below that is the quantified MG score, QMG, and one sees very similar responses. The ADL score is a patient-reported metric, physician-administered, but patient-reported, and therefore has more noise in it, whereas the QMG is a physician-derived outcome measure, and therefore the placebo arm is less. When we look at the adverse event profiles, one sees very similar responses between placebo and active drug in terms of headache, in terms of nasopharyngitis, diarrhea, and upper respiratory tract infection. Some individuals had a greater incidence of URIs in the drug-treated arm, but nausea, for instance, is similar. There were MG exacerbations, more commonly in the placebo arm, and one sees other adverse events in excess of 5% that are reported. But relative to the toolbox that we have currently, these adverse events are much more narrow and much less severe than we commonly deal with corticosteroids and azathioprine, mycophenolate, etc. Ravulizumab, I said, approved in 2022, is eculizumab, but engineered for an infusion of every 8 weeks. Because it's a complement inhibitor, it too carries a black box warning for meningococcal infections, and one must be vaccinated against it. This was called the CHAMPION trial. Again, there was screening. Standard of care was maintained throughout, and then randomized to active drug versus placebo. And then those who completed the trial roll over into an open label extension. Unlike the REGAIN trial, where patients had to have failed at least 2 immune suppressive drugs in the prior year, or failed 1 drug but required chronic IVIG or plasma exchange, ravulizumab was open to everybody with AChR positive MG. They had to have a disease duration of at least 6 months. And one again sees that the demography of these patients were quite similar. Again, predominantly Caucasian population with significant numbers, but much smaller Asian population, and then very rare involvement with other ethnicities. When we look at the severity of these patients, and again, most of the MG trials are quite similar, predominantly class 2, which is mild, class 3, which is moderately severe disease. Rarely do we have those who are severely involved because they tend to be poor clinical trial participants with a high rate of dropout due to worsening of their disease. But one sees that the MG-ADL score is almost 9, the QMG score 14 to 15, suggesting that these individuals have substantial disease burden. This graph looks very familiar to what you saw with eculizumab, placebo in red, active drug in blue. The time course is different. What you saw sort of appears to have lesser slope, but in fact it's very similar. Rapid, robust response occurring within 1 week, with the nadir reaching around 10 to 12 weeks and then sustained through the to the open label portion. And this is the activities of daily living score. Here, a virtually identical graph with the QMG score. Its safety was virtually identical to that which we saw with eculizumab. Predominantly grade 1, mild adverse events, and very few severe adverse events. There were some that felt to be related to the clinical trial agent. There were 4 deaths. These were unrelated to the drug itself, but were COVID, etc. The open label extension demonstrated findings much similar to what we saw in the blinded phase, as well as what we saw with eculizumab. There were no new safety signals. There were 6 serious events with listed here: dysphagia, tendonitis worsening, myasthenia, pneumonia, mitral valve. These were not felt to be related to the active drug. In each of these trials, there were no cases of meningococcal infection. My personal belief is that this is a numbers game, and patients who are on complement inhibitors will be exposed and will develop meningococcus. But given vaccination, given education, these should be quite few, far between. 4 deaths, COVID-19, and a cerebral hemorrhage, as previously noted. So the Iluka plan is a bit different. Approved here in 2023, it's a small macrocyclic peptide. It's subcutaneously administered on a daily basis. It's an aqueous solution. The injection takes less than 30 seconds. And this drug may be stored at room temperature. And as a result, offers the individual freedom of travel. One can put their syringes in their suitcase and go. The businessman, the family that's on vacation, or the student that has a very complex schedule and is on the move, if you will. And so there are some advantages in that regard. The RAISE study, as it was called, it was similar in design to what we saw with the first 2 studies, though the duration of the study was 12 weeks rather than 26 weeks. So patients were randomized, standard of care was maintained, patients were vaccinated, and then randomized to placebo or active drug. The dose that was used, 0.3 milligrams per kilogram, was chosen because our phase 2 trial looked at 0.1 milligram per kilogram and 0.3. And while patients got better at the lower dose, we had our best response with this higher dose, and that's why we chose it for the phase 3 trial. As you can see on the right, the demography was quite similar to all of our previous trials, predominantly Caucasian, secondarily Asian, and disease class, predominantly class 2 and class 3, with a few in the range of class 4. The MG-ADL score and QMG scores were similar, indicating a fairly significant disease burden. The ADL score in the range of 10, QMG score in the range of 18 to 19. Here's the blinded phase of the trial. Again, very rapid, robust improvement in the purple, which is the blinded drug, and then in the placebo arm, the placebo response in green. And this is the MG-ADL score, which again was the primary endpoint as mandated by regulatory agencies. You've seen the graph on the left just previously. In the middle is the quantified MG score, very similar. And then to the right is what I call the Christmas tree plot. And we were looking for 2-point changes in the MG-ADL score. But if I increase the stringency of response, what percent of the population had a 5-point change, or an 8-point change, or a 10-point change in terms of active drug versus placebo? And the more stringent I become, one sees a shift in favor of active drug. Below the large horizontal bar is what I consider the roots of the tree. And here we favor the placebo. These are individuals who had no change or worsening, and predominantly they were in the placebo arm of the trial. This shows the rollover phase, the open label extension phase. It was called RAISE XT. And again, on the left of the MG-ADL score, you've seen that which is in the white box already. And the dashed line is the placebo arm. And that rollover into the open label extension here in light blue, one sees again a very rapid, robust decline in the MG-ADL score that paralleled the original decline that then parallels that group that was already on active drug. And one sees additional improvement, suggesting that over the course of 24 weeks, there was still ongoing improvement in this metric. To the right is the QMG score, the first secondary endpoint, with a very similar response rate in the blind as well as the open label. So what are the pearls? MG is a clinical diagnosis, and I can't stress that enough. I've heard of a new quote that I think is very applicable. The problem with language, as we listen to reply, we do not listen to understand. And it behooves us as clinicians to listen and take a detailed history. The answers are in the nuances of the history. And we confirm this with our examination, and then also confirm it with serology electrodiagnostic testing. Our overarching goal now in current management is that patients have no symptoms with grade 1 or less adverse events. We've not been able to say that in the past using our current toolbox, our old standard of care, non-specific immune suppressive drugs. But I think we can achieve this goal with new targeted therapies. Clearly, our targeted therapies offer faster onset of action, and the adverse event profile is much more narrow than what we typically use. Complement inhibition targets the terminal complement pathway to reduce the formation of the terminal complement complex, the membrane attack complex, whose function is solely to architecturally destroy that neuromuscular junction. The complement activation is mediated by the presence of antibody to the acetylcholine receptor, and the binding of antibody activates C1QRS. Notably, patients with MuSK myasthenia do not activate complement because their antibodies are predominantly IgG4, and that minimally or doesn't even activate the complement system. All patients receiving complement inhibitors must be vaccinated against Neisseria meningitidis, according to local guidelines. In the United States, that's with a quadrivalent vaccine, as well as the B serotype, ACWY, and the B serotype. And the vaccines are different depending upon which one's used. The schedule of inoculation may be different. So one must carefully look at the product insert and do it appropriately. If one cannot vaccinate prior to the initiation of drug, then these individuals must be covered by an appropriate antibiotic. And remember, there are classes of antibiotics that have the potential to acutely worsen MG, so one must choose wisely. In addition, patients should be educated about the signs and symptoms of Neisseria infection. And all patients should carry a safety wallet card that they can give to their healthcare provider to let them know that they're on a complement inhibitor. And with that, I thank you. Have a good day.